And now, to begin the program, we welcome our Global Guideline Series moderators, Doctors John White, Joseph Mills, and Michael Conti. Doctors, the screen is yours.
I'd like to welcome you and thank you for joining us for this initial webinar of a series produced by the Society for Vascular Surgery to help with the translation of the Global Vascular Guidelines on the management of patients with chronic limb-threatening ischemia into our daily practice. The first session is directed towards medical therapy of patients with newly diagnosed CLTI. I am joined by my co-moderators of this series, Dr. Joe Mills of Baylor and Dr. Mike Conti of University of California, San Francisco, each of whom will moderate an upcoming session.
Yeah, thanks everybody for attending tonight. Session 2 is going to focus on Wi-Fi staging and use of the Wi-Fi calculator on the fly in clinic. And for that, you should make sure you download the interactive practice guidelines from the SBS, which has both the Wi-Fi staging calculator and the glass anatomic calculator. In session 2 on September 12th, we'll also address the relationship between Wi-Fi staging and patient outcomes, how to assess the perfusion of the foot, and the use of the Wi-Fi staging system to triage the care of patients with CLTI.
Thanks very much, Joe. Mike, you want to tell us a little bit about session 3?
Yeah, thanks, John, and good afternoon, everybody. In session 3, our focus will be on strategies for revascularization and how that's approached in the guideline. We'll have a panel of outstanding experts who will review the concept of a limb-based anatomic staging system, which in the guideline is the glass system, and how it's useful in everyday practice, and how you can use an online calculator to simply employ it. We'll also look at data linking the staging to outcomes, and we'll talk about pedal artery disease and also drug-eluting devices in our session on October 10th.
Thanks very much, Mike. The goal of these 3 webinars is to assist those caring for these challenging patients to better understand the recommendations of the guidelines and how to apply them to their own patients. We are fortunate today to have 4 brilliant speakers who have contributed much of what we know about advanced atherosclerosis through their own research and through their participation in nearly all of the major vascular trials. They will discuss optimal medical management of patients and focus on recent developments in blood pressure control and blood sugar control, lipid-lowering therapy, antiplatelet and antithrombotic use, and actual methods for enhancement of success to achieve smoking cessation in our patients. Rather than a simple review of all the available drugs, however, the speakers will focus on applying the guidelines to the treatment of a typical patient which is with newly diagnosed CLTI, and share with us their rationale for choosing their treatments. The patient is much like those I'm sure you care for as we do. It's a 72-year-old male with a 6-week history of an ulcer over the second PIP joint. He is a 1-pack per day smoker and a type 2 diabetic with a history of claudication. His left second toe ulcer has not healed despite daily local cleansing. His past medical history is remarkable for a small prior myocardial infarction. And on the basis of this, he was placed on aspirin 81 milligrams a day and metformin 500 milligrams a day. His past surgical history is remarkable for right toe amputation for osteo. His family history is remarkable for a mother who died at age 79 from complications of diabetes. As we move on to the physical exam is really noteworthy only for examination of the extremities. Both legs were warm throughout. There were 2+ femoral pulses bilaterally, but no distal pulses were palpable. The calves had no hair growth, and the feet were warm but slightly cooler than the calves. The right great toe amputation site remains well healed, and the remaining right toes have good capillary refill. The left toes have slower capillary refill. There is a small ulcer over the PIP joint of the left second toe. It is shallow without exposed bone. There is no evidence of infection, but there is also no evidence of healing and no healthy granulation tissue at the base. The wound is not probed to bone. There are no other areas of actual or impending skin breakdown of the left foot or toes. As we move to the laboratory studies, we can see that remarkable for a slightly elevated hemoglobin of 15 grams per deciliter and a platelet count of 200,000. His serum creatinine reveals a modest elevation, and his lipid profile is remarkable for a high LDL and a relatively low HDL with elevated triglycerides. He does have on ECG evidence of his old inferior wall MI. His hemoglobin A1C is 9% despite the 500 milligrams of metformin. The patient was then sent to the vascular laboratory for evaluation, as seen on the next slide. You can see the small ulcer there without any clear evidence of healing. He had a left ankle brachial index of 0.56 and a left great toe pressure of 37 millimeters of mercury. Next slide.
That is the last lab slide, Dr. White. But before you do continue, I just want to ask our attendees to please, if they haven't yet, complete the pre-survey. We'll compile the results, compare them to a post-test that we will ask everyone to take at the conclusion of the webinar tonight. And then this will be followed with a final survey 60 days from now to gauge and evaluate if the guidelines were easy to translate into daily clinical practice. And finally, all participants will receive clinical practice guidelines, implementation tools consisting of guideline pocket guides, and a link to the app to ensure practicality in aiding participants in improving their clinical practice. Thank you.
Thanks very much. Well, then let's get started with how we should begin to treat this patient to control the ravages of atherosclerosis. Our first speaker is Dr. Sonia Annan. Dr. Annan is professor of medicine and epidemiology and a vascular medicine specialist at Hamilton Health Sciences. She holds the Canada Research Chair in Ethnic Diversity and Cardiovascular Disease and is the Heart and Stroke Foundation of Ontario and Michael G. DeGroot Chair in Population Health Research. Dr. Annan is senior scientist at the Population Health Research Institute and director of the Chantlani Research Center at McMaster University. She obtained her medical degree and her training in internal medicine at McMaster University. She subsequently undertook a fellowship in thrombosis and then traveled to Boston, where she undertook a vascular medicine fellowship under Dr. Mark Krieger of Brigham and Women's Hospital. She then returned to McMaster University and obtained her master's degree in epidemiology and a PhD in health research methodology. She has been a principal investigator on most of the major vascular trials, including the WAVE trial, the COMPASS trial, and the Voyager PAD trial. She has shared her knowledge with us through more than 400 publications. Dr. Annan will now address this patient's blood pressure and blood sugar control.
Good day, I'm Dr. Sonia Anand, and I'm pleased to be here today to present on blood pressure and blood sugar control in patients with CLTI and PAD broadly. I'm a professor of medicine at McMaster University in Canada. You've heard earlier today about a case of a 72-year-old gentleman with CLTI who has some risk factors which require better control. The objectives today are to ask the question, should we treat blood pressure? And if so, what are our targets? And number two, should we aim for tight glucose control in patients with type 2 diabetes? The SVS recommendations suggest to control hypertension to a target of less than 140 and less than 90 millimeters of mercury in patients with CLTI. This is a grade 1 recommendation, strong, and the quality of evidence is B, or moderate. This evidence is important to review in the context of the patient case. Our patient had an elevated systolic and diastolic blood pressure at 165 over 103. When we look at the SVS recommendation and the trials upon which it's based, this is a reasonable recommendation. And we know, based on this, we need to treat our patient more aggressively with blood pressure lowering agents, and I'll review why that is. In 2022, we produced the Canadian Cardiovascular Society guidelines for PAD patients, and we cite lower blood pressure is better, in particular referencing the very well conducted large randomized trial known as SPRINT. And in SPRINT and other trials like it, there is a clear reduction in major adverse cardiovascular events, or MACE, described as MI, cardiovascular death or stroke, in patients with vascular disease. This evidence is supported by other trials in which blood pressure lowering reduces MACE. Other guidelines, such as the 2017 ACC-AHA hypertension guidelines, also assign a Class 1 recommendation for blood pressure lowering of systolic less than 130 and diastolic less than 80. Most of the data is focused on the reduction in cardiovascular events, and recent subgroup analyses suggest that perhaps there's a lower limit below which a patient's risk of cardiovascular events may increase, and this limit is less than 120 millimeters of mercury systolic. This has been shown in the INVEST trial and ALLPAC, and more recently and relevant to us, the Euclid trial, which was PAD patient focused, demonstrating an increased risk of MACE for patients who attain a systolic blood pressure less than 120. When we think about major adverse limb events such as acute limb ischemia, major vascular amputation, there are limited randomized trial data. Therefore, all things considered, including the subgroup analyses suggesting a lower limit of systolic blood pressure, it's very reasonable for us to aim to lower systolic blood pressure to a target of between 120 and 140 and a diastolic blood pressure between 60 and less than 90 millimeters of mercury. Thus, when we think about our patient, we could do better in lowering the blood pressure from 165 to 130 and 103 diastolic to 80. Often we're asked of the choice of agent, and randomized trials, including a large HOPE trial, as well as the smaller trials, suggest that the use of an ACE inhibitor or an ARB is an excellent first-line choice in patients with PAD, and likely the same holds true for CLTI. Next, we'll go to discuss the tight control of glucose in our patient. As you'll recall from the history, our patient with CLTI has a recent diagnosis of diabetes, and the hemoglobin A1C is around 9%. The SBS guidelines suggest using metformin as a primary hypoglycemic agent in patients with type 2 diabetes and CLTI. It's graded as a 1 strong and A high quality evidence. This evidence comes from the UK PDS trial primarily. This was an older trial in patients with type 2 diabetes in which metformin was compared to control and focused on both micro and macrovascular outcomes. UK PDS, as shown in the graphic in the lower right-hand part of the screen, demonstrated clear reductions in major adverse cardiovascular events and all-cause mortality, both short-term and longer-term. This provides a strong evidence base for us to initiate metformin with our PAD patients who have a newly diagnosed diabetes. And when we look for evidence with respect to the impact of metformin in reducing major adverse limb events, there are fewer studies that have data with respect to major adverse limb events. Metformin is commonly used as a first-line agent in patients with newly diagnosed diabetes, and it is a reasonable starting point in an outpatient clinic starting with a low dose twice daily and gradually titrating this up. Next, we'll go to the question of tight control. Is tighter control associated with reduced MACE as well as improved outcomes for patients with CLTI? Although some large trials, such as the ACCORD trial, suggested there may be some harms with aggressive tight glucose control, subsequent trials and a number of meta-analyses shows us that aiming for an hemoglobin A1C of less than 7% is associated with reduced major adverse cardiovascular events. So in our patient, improved glucose control will likely improve cardiovascular outcomes. In addition to metformin, which is an excellent first-line agent, shall we consider other newer agents? And the two that I'll highlight here include SGLT2 inhibitors, for which there is strong evidence that there is a reduction in major adverse cardiovascular events, especially in patients with PAD, supports the use of agents such as empagliflozin and dapagliflozin. We generally avoid canagliflozin based on some early results from the CANVAS trial suggesting an increased risk of ALI and amputation. However, the DECLARE trial, in which dapagliflozin was tested, enrolled 1,000 patients with PAD, and this subgroup analysis showed consistent reductions when an SGLT2 inhibitor was used for MACE and AM. There is increasing evidence that another class of glucose-lowering agents, such as GLP-1s, also support the reduction in MACE and male in PAD patients. So in patients with CLTI, although trials have been small, strict glycemic control is associated with improved LEM outcomes. Putting this together with the larger trials, it's reasonable in our patient to target a hemoglobin A1C of less than 7%. Thank you very much, and I hope this information is helpful.
Thank you, Dr. Annan. That was an excellent presentation on some very basic and challenging problems with patients with CLTI. We're going to move on next to Dr. Joshua Beckman. Dr. Beckman is professor of medicine at Vanderbilt Medical School, director of the section of vascular medicine, and director of the cardiovascular consultation service at Vanderbilt University Medical Center. He received his MD from New York University and completed his medical residency in internal medicine at Columbia Presbyterian Medical Center. He then completed fellowships in cardiovascular medicine and vascular medicine at the Brigham and Women's Hospital. He has been involved in both patient care and research throughout his career. His research, funded by both the NIH and the American Heart Association, focuses on the causative mechanisms of vascular disease and translating lab discoveries into bedside patient care. In recognition of his many contributions to our understanding of vascular disease, he has served as the recent chair of the Peripheral Vascular Disease Council of the American Heart Association, the past president of the Society for Vascular Medicine, and is the current chair of the ACC-AHA Joint Committee on Guidelines. Dr. Beckman has shared his knowledge of vascular disease with us through more than 250 publications. He is also an award-winning educator, having won teaching awards not only from Vanderbilt University, but also the American College of Cardiology and the Society for Vascular Medicine. He is the perfect person to discuss with us the use of statins to reduce the ravages of atherosclerosis. Josh?
Hi, my name is Josh Beckman, and I'm here to discuss the statin therapy and lipid management portion of this Guideline webinar. I want to thank the organizers of this program for the invitation. What is the problem? Well, the problem that we're dealing with is that patients who have PAD have really adverse outcomes. This comes from a randomized clinical trial, which is usually a population of people who have the best medical therapy and attention applied to them. This is Voyager, so these are patients who had lower extremity revascularization. And what you can see here, if you take a look at the left, is that all-cause mortality out to about 3.5 years was 12 to 13%. In addition, they also had a rate of about 20 to 25% of unplanned index limb revascularization. This suggests that the patient population has a really high rate of events and needs very aggressive management to try and reduce that rate of events. The problem is even worse, however, if you take a look at all comers. This is data from Medicare and Medicaid, and it included 16,000 beneficiaries, all of whom were admitted for FEMPOP artery revascularization in 2016. For the patients who had chronic limb-threatening ischemia, and if you can see this on the left side of the screen, there was nearly a 40% death rate out to about 3 years. And if you take a look at the patients who were revascularized not for chronic limb-threatening ischemia, you can see that death rate was about 30%. These are tremendously high numbers and suggest that the patients are extraordinarily high risk and need very aggressive medical therapy to reduce this rate of adverse events. Now, what is the medication utilization in these groups? Well, if you take a look at the box on the left, this is the medication utilization in patients in Medicare. And I'll just draw your attention to the bottom of the table, and you can see that only about 55 to 60% of the patients are on a statin, even though all of them have an indication for its use. One of the reasons outcomes is likely better in randomized clinical trials is you can see here that medication use is dramatically better with statin use between 80 and 85%. Even this isn't perfect, but it's much better than what I've just showed you. So if we move to our patient, the one that was described, we have a 72-year-old gentleman who has a 6-week history of a left second necrotic toe tip. This is someone with critical limb ischemia. He has a bunch of risk factors, including, as you can see in red, he's a smoker, and he has type 2 diabetes, all of which increases chances for PAD and CLI. But he also has EKG evidence of an old inferior wall myocardial infarction, suggesting that the patient has polyvascular disease. This further increases his risk. As we take a look at his lipid profile on the right, there's really not a lot of good news. His LDL is 160 milligrams per deciliter, and his HDL is just at the bottom end of where we would consider acceptable at 40 milligrams per deciliter. As well, his triglycerides are elevated. So what does that mean we should do? Well, really the most important study, the cornerstone or foundational study for the use of statins in patients with peripheral artery disease is the heart protection study. This was a very large study that randomized patients to simvastatin 40 milligrams or placebo, basically if they had any vascular disease or diabetes. And there was a 24% risk reduction in the rate of any revascularization procedure, major coronary events, strokes, and all these events put together. What's really interesting, by the way, is that the reduction in revascularization was almost evenly split between heart revascularization and leg revascularization. And the proportional reductions were the same in those with and without PAD, probably suggesting we weren't finding enough PAD back 20 years ago. Now, the use of statins has gotten better over time, but I wouldn't even brag about it. This is data from 2003 out to 2014. It's a national sample in the Veterans Association, and you can see here, taking a look at the triangles, that the use of high-intensity statins has increased. The use of lower intensities or no statins is declining, but it still, by the end of 2014, 25% of the patients were not on a statin. These are really unacceptable numbers at this time. One thing that comes out that's interesting, however, is that the higher the intensity of the statin, the lower the rate of mortality, as you can see on the left. High-intensity statins are in the top line, and also the lower the rate of limb amputation. Again, these numbers on the top line are the high-intensity statins. High-intensity statins are associated with living longer and better limb life as well. Based on data like these and other key references that are listed on this slide, the Global Vascular Guidelines on the Management of Chronic Limb-Threatening Ischemia, when they reference lipid-lowering therapy, suggest, if not recommend, the use of moderate or high-intensity statin therapy to reduce all-cause and cardiovascular mortality in patients with chronic limb-threatening ischemia. This is a strong recommendation with a high level of evidence, and you can see the heart protection study listed on the right, in addition to some of the other smaller studies that support the findings. Now, I want to say that we are now past just the statin era. It has been discovered that PCSK9, which is something that prompts the recycling of the LDL receptor, can be inhibited. And by inhibiting it and keeping more LDL receptor on the membrane, we can further reduce low-density lipoprotein concentrations. Whether or not this had a clinical benefit was tested in 2 clinical trials. This is one of them, the Fourier trial. It was a randomized controlled trial of evolocumab versus placebo. And in this trial, there were 3,600 patients who had PAD, and they were already on a statin. Okay, so this is therapy above the statin, and they were followed for a median of about 2 years. PAD was defined as intermittent claudication or an ABI of under 0.85 or a prior revascularization procedure. And I'll draw your attention to the figure, and what you can see here is that there was a 3.5% absolute risk reduction in cardiovascular death, MI, or stroke in patients with peripheral artery disease. The number needed to treat to derive this benefit was only 29. These are really large numbers. And actually, the absolute risk reduction was larger than in the patients without peripheral artery disease. This suggests that patients who have PAD would certainly benefit from more aggressive medical therapy. To get into this study, you needed to have an LDL of greater than 70 and be on a statin, hopefully the maximally tolerated statin that you could be on, and the benefit is obvious. You can see here that major adverse limb events were also significantly reduced. There was an absolute risk reduction of 0.9%. The p-value was 0.06 because the number of events were about low, but the trend is obvious and quite clear, begins early, and suggests that reducing LDL even further below 70 may have important limb benefits. The other interesting thing, and this is with alirocumab based on the Odyssey trial, this is a similar trial, although the patients had recent acute coronary syndromes. If you take a look at where the benefit lie when you got the drug, it turns out, as you see on the right forest plot, that it's not based on the LDL reduction at this level. It is, as it looks like on the left plot here, based on the reduction in lipoprotein little a. I think this is hypothesis generating because it's not been demonstrated prospectively yet. However, I do think that LP little a may be really important in the patients who have good control of their LDL cholesterol. I'm sure there will be more data coming to help us understand the role of these treatments and LP little a in PAD. So in summary, despite 2 decades of data, statin use in PAD, even CLTI, I think is mediocre. Statin intensity affects both mortal and limb events. High-dose statins should be the first line for PAD. Both PCSK9 inhibitor trials have shown a reduction in mortal and limb events. And in patients with LDL greater than 70 milligrams per deciliter on a high-dose statin and symptomatic PAD, PCSK9 therapy is FDA approved and should be considered. Thank you for your attention.
Josh, thank you very much for that outstanding presentation. It's very clear to us that we need to do a lot more in lowering lipid levels and using some of the statins and some of the newer lipid-lowering drugs. Our next speaker is also a phenomenal contributor to our understanding of vascular disease. Dr. Mark Banaka is the William R. Hyatt Endowed Chair in Cardiovascular Research at the University of Colorado and Director of Vascular Research and Executive Director of the CPC Research and CPC Community Health Centers. He is a cardiologist and vascular medicine specialist who received his MD degree from the University of Connecticut and is training in internal medicine, cardiology, and vascular medicine at the Brigham and Women's Hospital. He also received his master's in public health from Harvard. He remained on staff at the Brigham after his training and established the Aortic Syndrome Program and served as the medical director of the Aortic Center there. He has served as a principal of many of the major cardiovascular trials, as you saw with Dr. Beckman's presentation, including the TIMI trial, and he has specific interest in the ischemic risk in patients with atherosclerotic vascular disease, risk prediction, and risk modification through the use of pharmacologic and biologic therapies. He is globally recognized as an authority and thought leader for the care of patients with PAD and currently serves on the ACC PVD Leadership Council. He is associate editor of the journal Vascular Medicine. He has published more than 200 manuscripts and continues to be a leader not only in the treatment of vascular disease and its complications, but also its prevention. Dr. Bonaca is going to address recent developments and novel approaches in antithrombotic and antiplatelet therapy in PAD. Mark?
Hi, my name is Mark Bonaca at University of Colorado. I'll be talking about novel approaches to antithrombotic therapy in peripheral artery disease. These are my disclosures. I do want to spend a moment on the trials that underlie our current guidelines as we think about novel strategies. On this slide, you see the key pivotal trials. At the top for MACE reduction, the ATT was a meta-analysis of many small studies of aspirin at various doses and other agents, which showed that antiplatelet monotherapy reduced MACE by about 23% and increased major bleeding by 60%. The guideline writers have determined this risk-benefit is favorable and that this is a class 1 indication for PAD MACE reduction. Capri showed clopidogrel a little bit better, about an 8% relative risk reduction, and that was actually approved for PAD and again, a class 1 alternative to aspirin. Neither showed any limb benefit. And then other strategies like warfarin for the WAVE trial and DAPT with Charisma did not show benefit, and in the case of warfarin, really intolerable bleeding risk. So that gets a class 3 and DAPT gets a class 2B. In terms of studies for limb vascular benefit in the interventional setting, Dutch BOA showed that warfarin was not efficacious overall. There were some subgroup findings, a lot of bleeding. Casper, ADAPT was not efficacious after bypass surgery, and Camper never really enrolled. And so that then is the total of the data that we have. These are on the left side of the slide, the Casper trial, on the right side, Dutch BOA. Again, you can see overall no benefit, although there are subgroups with some hypothesis generating findings, a lot of bleeding, particularly for warfarin. In terms of endo, we don't have any randomized data. We have observational data sets. Here's one showing no benefit. There's some that do show benefit. None of these really meet the standard for efficacy and safety because they're not randomized. And so the guidelines are here. The 2016 guidelines are very similar to the 2005 guidelines. Antiplatelet monotherapy for MACE reduction. Clopidogrel is actually approved for PAD, aspirin's not. And everything else gets a 2B. The only other agent approved for PAD was Vorpaxar, and that's still commercially available and reduces MACE and MALE. So what have we learned since then? Well, the Euclid trial, I think, was a really important neutral in that it was totally unexpected. And we thought a better, more potent P2Y12 inhibitor would be the answer for PAD. But lo and behold, ticagrelor, even though it's more potent, less variable, and better in coronary patients, was no better than clopidogrel for MACE or MALE, and is not indicated in PAD, nor does it have a label there. But it shows us that this mechanism really wasn't the answer. So then, what is the answer? We know thrombosis is the issue. The rationale behind using anticoagulation actually was quite good. It's just that warfarin causes too much bleeding. And we see from pathological studies like this one that thrombosis and thrombin really are the core drivers of critical limb ischemia. When the targeted anticoagulants came and they showed us that targeting 10A or thrombin directly was much safer than warfarin. You can see in this meta-analysis that using these agents reduces intracranial hemorrhage and hemorrhagic stroke by 50%. And so there's been an enormous body of evidence now generated for the use of these at different doses for atrial fibrillation, for venous thromboembolism, long-term prophylaxis. And now we have data about very low doses, 25% of the full dose for rivaroxaban combined with antiplatelets to improve outcomes in PAD. And this slide kind of shows you the notion. It's not just about the platelet, but that we need to modulate thrombin-mediated risk. and factor Xa inhibition is an effective mechanism to do that. How do we know that? Well, we have probably more experience now in PAD with these agents than any others before them. This is the COMPASS trial, huge trial, about 7,000 patients with PAD that showed that aspirin low-dose rivaroxaban versus aspirin alone reduced MACE, mortality, male amputation, all significantly, and did increase bleeding by about 70%, but clear net benefit. And here you can see that no matter how you define peripheral artery disease, the benefits were consistent. Now we have a second randomized trial, a dedicated PAD trial in over 6,000 patients in Voyager, using the same dose of rivaroxaban here on top of aspirin or DAPT, again, validating that finding. I think in PAD, we've never had two trials for an antithrombotic agent that have confirmed efficacy and net benefit. And here you can see that combination reduced MACE and male after revascularization. There was an increase in bleeding, about 40% increase in relative terms, but a 6-to-1 benefit risk ratio overall. And you can see on this slide, the benefit risk ratio was very clear, 6-to-1 on the left, and that there were continued benefits over time. And so the notion of a very low dose 10A inhibitor added to antiplatelet therapy has been well validated in gold standard randomized trials. Now, there are questions. For example, what do you do about clopidogrel? And really the answer to that, as I showed you, is P2Y12 inhibition is not the answer here. You can use clopidogrel, but it does not act as a replacement for rivaroxaban. And maybe the clearest way to show you that is on this slide. Some people say, well, why don't we do a trial comparing aspirin and riva to DAPT? Well, why would you do that? DAPT is the red line on this slide. Adding rivaroxaban to DAPT reduces risk significantly, an absolute risk reduction of 2.3%, clear net benefit. How could you randomize people and put them on the red line? I mean, it would be unethical to do so. It's clearly beneficial whether or not you use DAPT. And the reason for that is because you're targeting thrombin-mediated risk, and antiplatelets don't do that. We can also see that in the endo patients, there's a clear benefit added to clopidogrel when you're looking at male events with a number needed to treat of just 42 just for male. And we also noticed that whether you have a prosthetic graft or a venous graft in bypass patients, that the benefit of targeting thrombin with this dual pathway approach is beneficial. Now, what about the CLI patient? Well, the CLI patient is particularly complex because of the high competing risks and the high risk of mortality. And so in terms of net clinical benefit, what does this strategy give us? Well, if you focus on the left side of this slide, in over 1,500 patients with CLI and Voyager, the combination of aspirin and rivaroxaban, or aspirin, clopidogrel, and rivaroxaban reduced the composite of irreversible harm events of the heart, limb, and brain, including all-cause mortality, intracranial hemorrhage, and fatal bleeding. And there was a number needed to treat of just 18. So we really have clear evidence of net benefit, including all-cause mortality in this population. But that's not the whole story, because we know these patients are high risk for recurrent events. And here, remember, the CLI patients that got into Voyager had to have a successful index revascularization. Despite that, 1 in 4 had a repeat revascularization over follow-up to that index limb. That index limb revasc failed. And adding rivaroxaban reduced the risk of that failure with a number needed to treat of just 17. And you can see that when you look at a total events analysis, that it's not just the first event, the second event, third event, fourth events are prevented by a more potent targeted thrombin combination of drugs. And of course, now rivaroxaban has been added to the list of drugs that have been approved in PAD. The only antithrombotic drugs that have been approved for PAD are clopidogrel monotherapy, Vorapaxar, and now rivaroxaban. And so this is in our armamentarium. And so I think as we think about incorporating these novel strategies, that for the high-risk PAD patient, the CLI patient, the patient undergoing revasc or polyvascular disease, you can see on the right side of the slide, even though, class 1 for antiplatelet alone, for these patients, we really should consider a more intensive regimen and adding rivaroxaban as the best studied drug, or alternatively, you could add Vorapaxar for risk reduction of MACE and male. And so these are some novel strategies, and I look forward to the panel discussion later. Thank you.
Mark, thank you very much for an outstanding presentation on a challenging subject. Well, we'll go to our final speaker of this webinar, Dr. John Gallage, and to show you that chronic limb-threatening ischemia is not a focal, regional, or national problem, but a global problem. John hails from Queensland, Australia. John is a preeminent staff specialist in vascular surgery at Townsville University Hospital and distinguished professor at James Cook University in Townsville, North Queensland. John trained at the prestigious Cambridge University and completed vascular surgery training in both the UK and Australia. In 2002, John joined the faculty of James Cook University, where he established and has since led the Queensland Research Centre for Peripheral Vascular Disease, aimed at improving our understanding of vascular diseases and improving our outcomes of their treatment. He has built the center into an amazingly productive research biology facility and examining many aspects of vascular disease and its prevention. He's served on the editorial board or as reviewer for many of the major cardiovascular journals, including Lancet, Circulation, Atherosclerosis, and the European Journal for Vascular and Endovascular Surgery. He has been a prolific contributor to our understanding of peripheral vascular disease with a vast array of publications, including 29 thus far in 2002 alone. With an interest in smoking cessation, Dr. Gallage will convince us that we can do more than just tell our patients to stop smoking. He will give us some methods for doing so. John?
Hello. Well, thanks to John and the organizing committee for this opportunity to talk at this important SVS seminar. So my talk deals with the best methods for smoking cessation. I have no conflicts of interest. So approximately a third of patients with peripheral artery disease are current smokers, and smoking increases the risk of major adverse events. In particular, failed revascularization and major amputation are increased in current smokers. So how do we help our patients give up smoking? The global guidelines include 3 recommendations highlighting the importance and methods to give up smoking in our patients. These are supported with a strong recommendation and a high level of evidence. Firstly, the guidelines recommend offering smoking cessation methods, including drugs, counseling, and behavior modification therapy, to all patients with limb-threatening ischemia. Secondly, the guidelines recommend that all our patients who are smokers or former smokers are asked about their current smoking status at each outpatient visit. And finally, the guidelines promote smoking cessation in any patient undergoing lower limb revascularization. So how do we go about helping our patients to give up smoking? There are 3 main methods: education, counseling, and a range of medications, including nicotine replacement therapy such as gum and patches, bupropion, and varenicline. A number of randomized controlled trials have investigated the effect of smoking cessation programs in patients with peripheral artery disease, and you can see these listed on this slide. I'd like to highlight one trial in particular, that of Henriques and colleagues. The senior author of this trial was the late great Alan Hirsch. In this trial, they randomized 124 patients to a holistic program, which included a brief vascular physician education session, cognitive behavior counseling to develop a quit plan, and this included motivational interviewing techniques, and finally, information and access to a range of medications for the symptoms of nicotine withdrawal. You can see the results of these trials in this slide in a forest plot. And overall, if we combine all these trials, if we look at the bottom diamond here, these trials showed no overall benefit in helping patients to give up smoking. However, the trial of Henriquez and colleagues stands out in tripling the likelihood, so we can see the relative risk here, of patients giving up smoking after 6 months. And I think the reason for this was the holistic nature of this program. So it included all 3 main modalities and also the quality of the trial itself. In other populations, a range of interventions have shown to be successful in helping patients give up smoking. These include behavior counseling, financial incentives, and SMS messaging. In terms of the medications for the symptoms of nicotine withdrawal and to help patients give up smoking, current guidelines strongly support varenicline as the preferred medication. This is recommended over the other options and also in combination with nicotine replacement therapy. It's recommended that this medication is taken for at least 12 weeks, and it can be started in patients who are not quite ready to set a quit date. So what do we need to know about varenicline? Firstly, it's contraindicated in schizophrenia, manic depression, suicidal thoughts, alcoholism, and acute coronary syndrome. In terms of starting the medication, there are 2 options. Firstly, we can suggest that patients set a quit date and start the medication a week before, or secondly, that they start the medication and then set a quit date between 8 and 35 days after starting the medication. The dose of the medication is 0.5 milligrams in the first 3 days, increasing to 0.5 milligrams twice a day in days 4 to 7. And from day 8, it's 1 milligram twice a day. We need to warn patients about a range of side effects of taking the medication. These are listed in the slide and include insomnia, dizziness, headaches, constipation, abnormal dreams, and worsening of psychiatric symptoms. Education is a key aspect of smoking cessation, and we can provide this in the outpatient clinic. Firstly, we should outline the harm related to smoking in a personalized way to the patient. For example, by emphasizing that this will worsen their current symptoms and the outcome of any treatment. We should advise patients that they need to set a quit date and look for support mechanisms from their family and friends to help them give up smoking, because they will have a range of symptoms from nicotine withdrawal. Again, these are listed on the slide and including anxieties, sleeping problems, difficulty concentrating, and anger and depression in particular. We should also advise them to avoid situations that stimulate them to commence smoking again, and also about the range of medications that are available to help them to give up smoking. What about behavior counseling? Well, this can become quite complicated, but there are some relatively simple counseling techniques, such as the 5 A's technique. In this technique, we ask the patient about their current smoking status. We strongly advise them about the importance of giving up smoking in a personalized way, and we assess their willingness to give up smoking. We then assist them with a quit plan and medications and counseling, as I've already outlined. And then finally, arrange the next appointment. What about patients who are not currently interested in giving up smoking? Well, this is a challenging area, but motivational interviewing techniques can help in these patients. Using these techniques, we express empathy and highlight the impact of smoking on their symptoms and risk to their limb. And we use techniques such as the 5 R's to assist them to give up smoking and develop a motivation to do so. This includes asking the patient to outline the relevance to them of giving up smoking, the risks for them of continuing, the rewards from giving up, what they envisage the roadblocks will be, and how they might get over these. And outline that repeated attempts are usually required to successfully give up smoking. So to conclude this talk, smoking is a key risk factor for adverse events in our patients with peripheral artery disease. So it's really important that we help them to give up smoking. We can do this through education, counseling, for example, using the 5 A's technique, and a range of medications, in particular varenicline. We need to follow up the patients, and this can be done in combination with primary health care facilities, according to local policy. But if this isn't arranged locally, we can follow the patients up at 6 weeks to 3 months to see how they're going with their smoking cessation. So finally, there are a range of important references listed in this slide that give further details of how we might assist patients to give up smoking. So thank you for your attention today.
John, thank you for another extremely informative and very, very important talk. I'd like to thank all of the presenters for great presentations and ask them, along with my co-moderators, Joe and Mike, to turn on their cameras and join us for roundtable discussion, where we'll go over many of the questions that were asked by the viewers. So as we gather additional questions, let me begin with a few of my own. So Dr. Anand, in trying to push down hemoglobin A1C, is it better to use combination therapy, or is it better to just keep pushing metformin to the 1,000 milligrams or beyond?
Thanks, John, for the question. I think likely all of us will use metformin as our first line drug, and we started off low and go slowly to prevent the side effects, typically GI. Most of us start with 500 BID. I think the most effective dose range is between 1,000 and 2,000 milligrams per day. And so I would increase the metformin until I reached a maximum of 2,000 a day, so 1,000 BID. And if you're still not getting your hemoglobin A1C in the target, then add the second agent at that point.
Thanks very, very much. My next question is to Dr. Beckman. If we see a CLTI patient without a significantly elevated LDL, even within the normal range, should we start them on high-dose statins? Should we continue to really push to minimize that LDL in those patients?
Yeah, I would say so. I think that there's enough evidence now from retrospective studies and also from some, I would say, collateral trials looking at coronary disease, where more intensive statins always have better outcomes than less intensive statins. And there's never been a trial demonstrating a lower bound for the level of LDL that one should obtain. In the Jupiter trial, there were a whole bunch of patients with an LDL of 0, and they did fine. So we don't have to worry about getting too low. I also think that there are other ancillary benefits that come with being on a statin besides just LDL lowering. This is a point of contention in the lipid community, whether or not there's a true inflammation effect. But my answer to that is statins seem to work better than every other oral medication by far. And so that tells me they're doing something else as well. I would say that no matter what level you come in on, patients who have peripheral artery disease should be placed on a high dose statin and set it and forget it. get to the point where you get the LDL below 70. And if you don't, I gave some other possibilities in the talk with PCSK9 therapy.
Great, thanks very much, Josh. Dr. Banaka, there's a great deal of interest in the Xarelto type compounds, the anti-10A inhibitors. And so a couple of the audience members have asked two general questions. One is the benefit of low-dose Xarelto and low-dose aspirin specific to Xarelto, or is it shared by other anti-10A inhibitors such as Eliquis?
Yeah, it's a great question. I mean, it would, when we were just talking about statins, there are many statins out there, and really it's just about the potency and the LDL that you achieve. And so I think it's intuitive to think you could use any of the 10As or DTIs and get the same effect. I think the issue, though, is unlike cholesterol lowering, where there's no lower bound for safety, as Dr. Beckman said, we know with anticoagulants that it's very different. And when we reach for the other agents, we don't have doses that have been studied in arterial disease. So specifically for apixaban, there was a trial called Appraise, which looked at acute coronary syndromes using this sort of standard dose of apixaban, and it was stopped early because there was no benefit and overwhelming harm for bleeding. And so I think the main issue with extrapolating, it's not, which name of the drug you use, it's really the dosing. And, through the Atlas trials, through the Compass trial that Sonia led, and through Voyager, we know that about 25% of the total daily dose of rivaroxaban has a net benefit in this population. I think using apixaban even 2.5 would be about double that dose, and I think would be probably unsafe and unproven. So I think by mechanism, it would be reasonable to consider, that others could, but without doing the trials to find the right dose, I think it's unsafe to use another agent.
Thanks very much, Mark. And Dr. Gallage, when you talk about seeing the patients in 3 months to monitor smoking cessation, do you just simply ask and take their word that they're not smoking? Do you ever measure serum nicotine levels, or try to add any hard data to determine whether they have indeed decided to stop smoking?
Well, thanks very much. Great to be here, and thanks for the question, John. So no, I don't normally. Personally, I've been involved in measuring cotinine and carbon monoxide in a number of clinical studies for research purposes, but it doesn't necessarily engender a level of trust with your patient. So personally, I don't do that unless it's a requirement of a study that we're carrying out. I rely on the patient discussing things with me. I know that they may not give us always the full story, but really I think we have to see smoking as something that we're helping patients to give up, rather than that the patient is doing wrong, because we really need to engage in helping them achieve risk factor control, and it's just another risk factor, really. So I don't think that it's perhaps the best way of engendering trust.
I agree. Thanks very much, John. I think this is something that we all, as vascular patient healthcare team members, need to really push smoking cessation. We talk a lot about it, but you rarely see in the vascular literature a significant number of methods that have been tested and results. There have been a lot of questions, obviously, on antiplatelet agents and antithrombotic agents, and I know that Dr. Conti shares many of those questions. So Mike, why don't you go ahead?
Yeah, just a couple of questions. First of all, the talks were outstanding, so thanks to all the panelists. Mark, maybe you can say a few words about bleeding risk in a patient with CLTI who's presenting for revascularization, which might end up being open, or you're not sure exactly what. When can you say is the safest time and most efficacious time to start the treatment based on the results from Voyager?
It's a great question. These therapies, I mean, as you see from Compass and Voyager, for long-term prevention, and therefore in a very acute setting, there's no rush to add it as you're sort of figuring out what to do and when. And in the trial, guidance for the sites that were participating was to begin the therapy. It was within 10 days, but when the operator or when the treating team felt that they had achieved hemostasis. And it turns out actually the investigators, the clinicians were really good at figuring that out. When they felt, it was safe, they weren't going to do any more work, they were able to start it. And when we looked at procedural bleeding in the trial, there's no difference actually between rivaroxaban and placebo in those early bleeds, because the clinicians were quite careful about when they started. So I'd say anytime that a few days after you're done with your last procedure, it's fine to add prior to discharge.
Great. And Josh, just to follow up, because I know a lot of possibly vascular surgeons, to follow up on one of John's questions, may find they're a bit of an obstacle to taking a statin naive patient right up to, high dose statin. Not that it should be too much of an issue, but can you just go through very quickly how you approach with the discussion with the patient, and also any monitoring or any side effects that really are usually not dose dependent anyway, but how do you actually do it with the patient conversation?
So when I start this conversation, I basically tell patients that the drug that has saved more lives than any other in the last quarter century are the statins. There's just nothing else that comes close. There's no cancer therapies. There's nothing. And so I tell them that I would like to save their lives and their limbs too. And then I say, you know what I put everyone on? Everyone. I start them on atorvastatin 40. Why do I do that? Because I just do that. If they don't want that one, I'll put them on a different one, but that one gets almost everybody to goal. And if not, or they have some difficulties with muscle aches and stuff, I'll stop it. And I have other ways of getting around that with low dose rosuvastatin that I can give every other day because it's a very long acting drug. But there is no downside to this medicine. And I think if you tell patients that you're not putting them on the maximum dose, but 40 of atorvastatin is actually really a high dose, they're all right with it. They don't feel like they're too sick, and you get kind of the benefit you want. I think the other thing, I will say that there is no monitoring really anymore. We don't do that. So it's a set it and forget it kind of thing. I check the lipids after about 4 weeks just to make sure I've hit my goal. And then it's an annual check the cholesterol when they're in your office kind of deal. If there are people who will have ridiculous lipids and then you have to do some more stuff, but the majority of people, even diabetics who commonly start lower with their LDLs, you'll get them to where you want to get them with 40 of atorvastatin. And if you don't, then, the surgeons should probably send them on to talk to their internist for the second line agent or third line agent, depending on what's going on. But I would say if you're able to cut into a leg, you're able to give someone a statin.
And
That's a great vote of confidence.
one last question for both you and Mark. The PCSK9 inhibitor stuff is obviously very exciting. And, we've all had, I've had some patients have just incredibly dramatic, rapid reductions in their LDLs on these. But there are some obstacles. And it's also an equity issue a bit, especially you sort of inferred that there may be larger benefit than even maybe the current guidelines are suggesting for how they're used. So for the people in practice today, as far as getting patients on these medications and having them covered, what's the current state and what's maybe coming?
You, Mark, go ahead.
Well, I'll say first of all that the guidelines are going to change. I'm not no specific knowledge, but I'll say at least the ESC guidelines have now advocated for a threshold of 55 milligrams per deciliter, and for these high risk patients, the data would suggest you probably want them around 30, and so the proportion of patients that need a second drug is going to grow. I think initially when these came out, they were super expensive, and the insurance companies just said no matter how correct it was to order it. That's really changed. Prices have come way down. They're easier to get. I would say if you're in practice, what I do is, get to know a good pharmacist who can help you with all of the back and forth. And I've had patients that, I'll prescribe evolocumab, and then a year later, the insurance company wants alirocumab or some other mab. And, they can really help you with the paperwork for that, so you don't waste a lot of time. And then coming down the pike, there are oral PCSK9s. There's even inclisiran, which is, a small interfering RNA, which is a once every 6 month injection, and you can actually give it in the office. And the model that, Novartis, which is the manufacturer, is advocating for, is actually like an infusion center kind of thing for oncology, where you can actually bill for the injection. And I'm not saying that to make money, but it certainly streamlines and resources your practice to give it. So I think there are going to be a lot of options for these therapies. And then, on top of that are going to come the LPA drugs. So it's going to get more complicated, but they're going to be easier to get. And I do think there's an equity issue that needs to be addressed.
I just want to add that I've commonly used ezetimibe as a second-line agent as well. It's oral, it's easy, it's one dose, and it's much less expensive. And so, there's already been the combination ezetimibe and statin trials done together, so we know that they go together fine. And you routinely get a 15 to 20% further reduction in LDL. And I will use that as a way to get the LDL well below 70 if the other drugs become difficult for the variety of issues that were mentioned.
Thanks, Josh. We've had a lot of questions and phrased slightly differently, but the questions largely are the timing of the statin therapy, better glucose control, the antiplatelet, antithrombotic agents, relative to the timing of a perceived necessary intervention. Is it necessary to have statins on board? Should they have, rivaroxaban plus aspirin plus Plavix on board? How important is it to get the hemoglobin A1C down to 7? Are these essential landmarks prior to intervention, or is this, well, it's going to be lifelong therapy, so it doesn't really matter its timing relative to the intervention? I throw this to all the panelists.
I'm going to take a stab first, if I can, John. And
Sure.
I mean, as a non-surgeon speaking to a surgical audience, surgery is one aspect of care, only one. And PAD is a chronic disease. And this medication should be started whenever a physician with the knowledge has a PAD patient in front of them. And so I think that should be a principle going forward. It's kind of somewhat, for me, an artificial boundary to say pre or post surgery. I think when we see them, if we have the knowledge and the ability to start the drugs, we should. Many of us, and I'm sure your colleagues and attendees, operate on patients who are on the low-dose rivaroxaban aspirin regimen without difficulty. We've shown that, that's really important to have PAD patients on that regimen when they're symptomatic, to prevent major adverse limb event in the first place, not just ALI post-procedure. And patients who are on that regimen, when they do suffer ALI, have a much better prognosis. And I think for the antithrombotics, I'll make that point. For the statins, we have and cholesterol lowering evidence from different vascular beds that you can stabilize plaques if you get patients on lipid lowering drugs. So I think that's a yes. And then also tighter glucose control in diabetics undergoing any procedure improves their prognosis. So I'm giving a yes across the board that it's important to have them on these medications pre-surgery.
Can I add one thing to what Sonia said? And you can take your hand down because I won't disagree with you. I really want to separate two things here. So the statin and the low-dose rivaroxaban are basically single-dose drugs. You're not going to make a lot of changes right, around the time of a procedure. you're going to just start it. Blood pressure control and and glucose control will never be completed in 2 weeks or 3 weeks or 4 weeks. This is an ongoing management issue that requires a bit of, a bit of care and repeat visits or conversations with the patient. And so what I think is the responsibility of a surgical audience is that you have to really consider making this a point to the person who's going to do this work. You guys can do the aspirin or rivaroxaban. You should do that after the procedure. It's been demonstrated in a randomized clinical trial. You guys should do the statin because it's one dose of one drug. Choose the drug you like and just start it. Blood pressure control and glucose control should be something that you may want to participate in, but I would say more realistically, you need to get in touch with the cardiovascular person, the internal medicine person, the diabetologist who's going to be doing this work. And that's never solved in 4 weeks. But you need to tell them that this is very important to their vascular outcomes. And so I am telling you that I need this work done. And this is not an area where I feel comfortable running the show, but I'm endorsing this work strongly.
Thanks, Josh. John, how about in Australia? Is there any general rule of thumb about using these drugs, starting them before interventions, et cetera?
Yeah, so I agree with what's already been said, but it depends a little bit on the patient, doesn't it? And what the limb problem is. So we're talking about patients with chronic limb-threatening ischemia. So some of these will be very urgent. So they may come back with acute limb ischemia, etc. And as has already been said by Mark, the low-dose rivaroxaban, personally, we're not starting that straight away in hospital. We're tending to keep the patient on clexane or heparin for DVT prophylaxis while they're in hospital, in addition to whatever other treatments, so using low dose if it's just DVT prophylaxis. And when they're leaving, we're then starting the low dose rivaroxaban. So I think that's the anticoagulant's a bit different than the other aspects. Clearly, there's a lot of evidence, as already been pointed out, that patients on statins do better perioperatively, lower risk of cardiovascular events in the perioperative phase. So really important to have them on a statin. So I think it depends on the agent a little bit and the individual patient, how rapidly you have to get going on things.
Thanks very much. So your answers have addressed a large number of the questions. Again, not the least of which is, as your outstanding vascular medicine specialists, what do you expect from your vascular surgery colleagues? There were questions of who should be starting these drugs, which I think that you have explained quite well, and I appreciate that. So there is, another question about, the drugs, the recommendations, so that Dr. Annan, you recommended, ARBs or ACE inhibitors as excellent for blood pressure control, especially in patients with vascular disease. So the question is, what if the patient has good blood pressure control on different medications? Is the benefit of the ARBs or the ACE inhibitors sufficient to warrant changing from hydrochlorothiazide or any other antihypertensive to control their blood pressure?
But that's a really good question. I think our biggest challenge is often getting blood pressure under control. So it is relatively uncommon to have a PAD patient who has good blood pressure control on a single agent. If that is the case, however, and you repeatedly see a 120/80 blood pressure in your PAD patient on, say, a beta blocker, I wouldn't change it because they're getting good control. If, however, you need a second agent, then I would choose an ACE or an ARB as my next choice. However, I think the alternative scenario is more likely, where we often do need at least 2 agents, and therefore the majority of our patients get onto an ACE or ARB because of that.
Thanks very much.
Excuse me, Dr. White.
Yes.
Just before you continue the discussion, just wanted to alert all of the attendees that the post-event test has been launched. As with the pre-test, we do ask that all attendees please scroll through the answers to answer all 18 questions, and you'll only be able to click the submit button after you answer all of the questions. We'll compile the results soon so that everyone can see those combined results. This will also be followed with a final survey 60 days from now to gauge and evaluate if the guidelines were easy to translate into daily clinical practice. And finally, all participants will receive the clinical practice guidelines, implementation tools consisting of guideline pocket guides, and a link to the app to ensure practicality in aiding participants in improving their clinical practice. Thank you.
Thanks, Pete. So one other question from an audience member directed to Dr. Galich, but I would ask all to chime in. So the question is, when after smoking cessation, do you believe the risks imposed by smoking begin to subside? Do you have a sense for that?
Yeah, thanks for the question, John. And so I think the evidence really points to a year after smoking cessation, there's evidence that your risk is reduced. And, you know, when does a current smoker become a former smoker? I mean, we don't have any, you know, hard evidence, but certainly there is some evidence pointing to after a year, your risk is reduced. So I think there really is a value. I mean, in our registry, for example, current smokers have a mortality that's twice that of former smokers. So this is the sort of thing that I explain to patients, because often you hear the damage is already done, why stop? And I've explained that to them on numerous occasions, that really there's a lot of evidence. And adverse events that we're trying to prevent are things like stroke, which have a major effect on your quality of life, for example, or losing a leg. So these are the sort of conversations I have with patients when I'm talking about this.
Thanks very much, John. Mark, Josh, Sonia, do you have anything to add?
The only thing I would add is that I think, and I saw this question in the list, you know, how do you work better with your internal medicine colleagues, for example, and primary care doctors? I can tell you as a cardiologist, for example, that when I start a medication, I start medications routinely that I think are important. And the internists are really happy to know that I've started a medication that's important for the problem for which I'm seeing the patient. So you guys should not hesitate in starting the aspirin or rivaroxaban or statin, because it is in your purview of activity. There's no internist has the words, wow, I'm really annoyed that someone else prescribed a medicine for which they're an expert, are words I've never heard from an internist. So I think that the idea that you're taking someone else's space is really just an excuse not to do it. So just do it.
I've only heard that from a cardiologist, Jeff. Yeah, that's the only people I hear from, as you would imagine. And just back to Jonathan's point, I would add that, you know, within 1 year makes sense. And then we can think about a whole host of outcomes from mortality, but also patency. I know you've got great data in the surgical population that, you know, 5-year patency after aorta bifem is much, much higher, and 95 plus in a non-smoker compared to a smoker. And the observational epidemiology would show and suggest that once you quit, your risk of what we call MACE and mortality equates that of a non-smoker by about 5 years, and then completely no long-term effects after 10 years post-smoking. So the immediate post-surgical patency outcomes, and then the longer term is bringing that MACE risk back to the general population.
Yeah. And thank you. I mean, it is crucial to really find, effective methods to stop smoking cessation. It just, it really does steal from the patient a good durable result. I mean, you do the carotid endarterectomy. It's a great operation, but what's the one factor associated with recurrent disease? Cigarette smoking. So I think it's crucially important. I really love to see more papers in the literature saying we tried this method and these are our results, so we can begin to develop some benchmarks for really pushing these critically ill patients. Mike, you had a question?
Yeah, another question for, I think, Sonia and Mark. We talked about today is a new patient presenting with CLTI, but I wanted to talk about maybe an established one. So, and the hurdle of starting a new antithrombotic, let's say a patient who, is maybe even status post BKA in your regular follow-up clinic 2 years later, or, has had a successful revascularization. They don't have any symptoms of CLTI right now. They're kind of going along relatively stable on last year's therapy. How do you approach that? And maybe share a little bit of your insights from the experiences from the studies.
So you want to go ahead?
So, sure, and then over to you. Thanks, Michael. And I think just using the COMPASS data, we did see that patients with PAD, and that included prior revascularization, had a substantial reduction in what we called major adverse limb event, which was ALI, severe limb ischemia requiring an intervention, and major amputation. So that was really clear. It was almost too good to be true, but then Voyager came along and backed that right up. So I think, one BKA is quite disabling, but a bilateral amputation even worse. So, even though they've had the worst outcome on one leg, I would go about saying you're a high risk individual. I'm going to switch you from single antiplatelet therapy to I call it the COMPASS regimen or the Voyager regimen. And now over to you, Mark, because you did have a large percentage of Voyager being CLI patients.
Yeah, no, I agree with you, Sandy. I think it's the hard part about prevention, Mike. It's that, someone comes in feeling fine. This happens with post-MI patients too, and you need the inertia to make a change. And so people really need to understand the risk that they face, even though today they feel okay or that they're quote unquote stable. And I think that's a challenge for patients and for clinicians, because when you got 15 minutes, how deep do you go into this? But I think the reality is that once they've had CLTI, they're forever a different patient. No matter how good they feel on any given day, they're really facing not just, amputation of the other limb, but strokes, heart attacks, cardiovascular death. And so you want to do everything you can to help them live as high quality life as long as possible. And that's the role of the medications. But I think you have to get into that risk profile, which no one really wants to hear when they're feeling okay. But I think it's absolutely crucial to get them on the right meds. The other point I'll make, just going back to the earlier discussion around choices of medications, is just to be careful that most of these patients have a lot of comorbidity. So, when would you use an ACE inhibitor? Well, remember, there's some patients that may have another indication for an ACE inhibitor, like they have diabetes or kidney disease. And then therefore, even if they're on a beta blocker and well controlled, they still need to be changed. You may not feel comfortable making that decision, but just be aware of that. And same for the diabetes drugs, that there are whole classes of drugs out there that are benefits independent of blood sugar lowering, where patients are going to be on an SGLT2 because they have kidney disease or heart failure even without that. And so just be aware that you're going to see a lot more drugs in these settings, and that the staging may depend on their comorbidities.
Thanks very much, Mark. We're getting towards the end of the panel discussion, but there are a couple more interesting questions. One is, again, for Dr. College, if you have someone that's smoking four packs a day and they cut down to 1 or 2, are they in better health, or is all smoking a real problem?
I think what we're aiming for as physicians is patients to give up. Really, that's where the evidence base is. There's some data certainly that the amount you smoke is relevant, but I often hear that from patients. I'm cutting down. What we should be doing is encourage them to stop and set a quit date and working with them about the advantages of that. And if you go back to the examples I gave in the talk, there are some techniques to try and in a considered way and an empathetic way to get them round to what they personally are going to benefit from giving up smoking. So I think that should be our aim, rather than helping them to cut down. We should be helping them to quit.
Thanks very much, John. The last question I have is, and Josh, you talked about vascular surgeons starting meds, but I leave this for all of you, and that is, if you have a CLTI patient, on a statin, on rivaroxaban and aspirin, who gets a graft put in for limb salvage, the graft fails, they're progressing towards amputation. If a vascular surgeon has to redo a graft, now they want to do something different. So frequently they'll add, Plavix to rivaroxaban and aspirin. They'll change the dose of statin, go to a different drug. We're creatures of habit, and we want to make something better. So what are your thoughts? I mean, if you have a CLTI patient that you're treating and they seem to be failing, where do you go with that?
Oh, it's so nice you're asking me to discuss my approach to a surgical problem. So the first thing I do is I want to make sure that there's no mechanical problem with the graft. If there's early failure, it fails to mature, the graft doesn't enlarge during its surveillance time, it tells you there was a graft problem. And then I'm going to leave that to the person who's going to put in the graft. The second problem is that there's an underlying or otherwise undiscovered inflammatory lipid problem with the patient. This is the setting in which I've been measuring a lot of Lp(a)s. And I never measured this before 2 or 3 years ago. And now every time someone has a graft failure that's more than a month out, I seem to find it in every third patient. I also begin to look for other thrombotic reasons why patients may have this problem. That's a much rarer circumstance, but it occurs as well. And then there are people who just seem to have the most aggressive atherosclerosis, and I can't figure out why that is, but they just do. I think what you're really asking me is, when do I move towards full dose anticoagulation? And the answer is as rarely as possible, because we know, for example, that warfarin knocks off people with PAD, as demonstrated by Dr. Anand in her WAVE trial. And so I'd rather not trade lives for limbs. And so it's only really when we're talking about prosthetic grafts, because there's no vein that's really available. And now it's not that it's uncommon, but we're talking about individualized care at this point, because there is no standard management at this point for those patients. And so I don't really have a great answer, because I don't think there is a great answer, and we're all sort of making it up at that point.
All right, Mark.
If I could jump in there on 2 points. One would be after Jonathan's remarks on smoking. I'd say the observational literature does show there's a clear dose response in terms of number of cigarettes smoked and disease. And so our ultimate goal is, of course, patients quitting, but I also do discuss that a reduction of 50% of their smoking will make a difference. And that could be considered a first step, and then ultimately trying to get to zero. Also presenting to them that smoking addiction is like a chronic disease, like diabetes. There'll be times where you're not smoking, other times when you're smoking, and we're going to stick with you through all of those times and help you. And then to Dr. Beckman's point about graft surveillance and And, patients who have a lot of, challenges with restenosis, lipoprotein(a), I fully concur, is important to measure. And our Canadian lipid guidelines do recommend we measure Lp(a) in all patients at least once in their lifetime. It's not a molecule that's going to change over time. It's 90% genetically mediated. So I think it's useful if you look at your EMR, look for the Lp(a). Has it been measured once? Once is enough, but at least do it once.
I agree with all those comments. And I think for the LPA, the European and Canadian guidelines advocate for it. In the US, it's not. And so there may be insurance coverage issues. People will get charged sometimes, but it's not, I mean, it's expensive, but not unfeasible. And then I am using PCSK9 inhibitors in patients who have controlled LDL, but very high LPA, and they have these recurrent events because you got to do something different. Whether that strategy bears out, there'll be trials of LPA inhibiting agents that'll prove that. But I'm convinced enough in those sick patients, you have to do something. And then I think for the prosthetic grafts, I agree with everything Josh said. I'll just say I think factor 11 is on the development pathway and is really important for contact-driven thrombosis. Prosthetic materials, and I think holds a lot of promise there. So hopefully we'll have a better answer for you next time.
That's outstanding. Listen, the discussion has been excellent, and I can't thank you all enough. We have just a couple things. What I'd like to do is go over the test results and see what the general spectrum of knowledge is amongst our attendees. But before we get to that, the next two webinars are going to be much better understood if you download the SVS app. So, it's a free app that you can get from the App Store. And the benefit is it contains a lot of information about the guidelines and the recommendations provided by the guidelines. And then, Joe, you want to talk about the calculators? You're muted, Joe.
The calculators are really useful. So they've been updated. So you can calculate Wi-Fi right in clinic. You can calculate when you get to the point where you get an angiogram, you can calculate glass. And these are intended to be used. So the calculator makes it easier. It reminds you, if you're not sure what separates a grade 1 from a 2, for example, you have choices you can click on. So, and then so our session will mostly address on using Wi-Fi to stage patients and kind of triage how you move them through the system and how rapidly you need to pursue limb salvage revascularization, for example. And then the last session, Dr. Conti's will focus more on using plan and glass as logical ways of working your way through the revascularization options based on the limb stage, which is Wi-Fi, and the patient risk calculator, which is also in there, which was derived from a very large patient data set.
Yeah, so I and my team have found these calculators extremely useful. So, I'd strongly encourage, the attendees before the next webinar to download it and become familiar with it. So let me just check before we adjourn. Do we have the test results available as yet?
I am checking on that, Dr. White. You just stand by for a moment. I think we have maybe time if you have another question or two.
If there was one question that was asked early, so this whole session's been about CLTI patients, but we also see PAD patients that don't have CLTI, particularly claudicants. And one of the early questions was, what about if you're getting ready to do a procedure on a patient with claudication, they're not on a statin? Is it worth starting them on a statin and pursuing exercise therapy for some more and before you consider an intervention? Dr. Beckman or Anand, whoever wants to tackle that.
My preference is, let's separate out those two questions. One, everybody should be on a statin. The management of lower extremity symptoms, I think, should be exercise first. I will talk about, say, the CLEVER trial, where even with exercise first, most people did not reach the feeling of being normal. And so there will be a subset of patients who will go on to need some kind of thing to allow them to be able to participate adequately in their daily activities. But I also find from recent work from Mary McDermott that quality of life and how people feel about their walking changes almost independently of actually how much their walking increases, which really makes me wonder what we're doing at all with the claudication population, period. So I think we have a lot of work. Like everything I thought was kind of boring and standard has turned out to be neither boring nor standard. And I don't really understand how it's working anymore. So I think there's a physiological change and there's an emotional change, and their relationships are poor.
Yeah, I think so. For the CLTI populations, to me, it's easier. I think this is a great opportunity to talk to them about this is a disease they're going to have for their whole life. And even if we save that leg is still at risk and the other leg is at risk. And so part of keeping them in remission, and I learned this from David Armstrong, but we talk about keeping the patient in remission. So you try to keep their wound-free period as long as possible. That's not just the intervention, it's all the medical care that they have to get. So I used to not do this. I used to send notes to the primary care docs, but now I start statins. If they're not on a statin, I start them. And if they're not on, I've started using more and more rivaroxaban. Blood pressure is a little different because sometimes you have to add agents in the hospital that may not reflect what they have as an outpatient. But I try to make sure when I do that, I send a note to the referring doc. You know, we noticed this patient has all these risk factors for PAD and in fact has had CLTI before and they weren't on a statin, or, you know, we added rivaroxaban based on the COMPASS trial, and I hope you agree. And I haven't gotten one nasty note back or anybody upset. So I think that we're seeing these patients. And so I agree with Dr. Anand. If you're in front of that patient, it's probably your obligation to start the stuff you're comfortable with. And for vascular surgeons, we should be comfortable with statins and antiplatelet therapy and rivaroxaban. And I also think it's really important. I do this with claudicants too. I spend more time with claudicants in clinic than CLTI patients, trying to get them to understand that it's not the intervention that's going to cure them. And then every time it fails, you come back and you cure them again. That's really not what I'm after. I'd rather never operate on them. And so actually, if you have that conversation with them and talk about all the risk factors and send them to the specialist you need, like obviously glucose control, we're not going to do that, right? Hypertension control is going to have to go to their primary care doctor, their internist, or their cardiologist. But we have that conversation. And I try to follow up on that every single visit. I mean, it takes a little time, but I think that's part of our obligation. This is a disease. It's not just a segment of arterial occlusion or stenosis.
So just one quick other thing is, like, just get back to our patient for one last minute, is pretty much everything we've talked about today is mid and long-term risk. We didn't really touch on the question about peri-procedural risk, which is a whole nother kettle of fish, but we have experts on this call right here. So just really quickly, that patient or someone even, let's say, with a more dramatic foot presentation, you're trying to get them ready for surgery right away. Can you just quickly review how you approach it? Because everything we talked about, as I said, was not focused on that.
Well, I am the founder of the Society for Interventional Nihilism, or SIN, prior to surgery. I think over time, separately from surgery, we have learned that stable coronary disease does not benefit in the short term in any way from revascularization. So rule number one, don't do before an operation what you wouldn't do independent of the operation. The second thing I would say is that I think heart failure is becoming a bigger problem than coronary atherosclerosis around the time of surgery. That is because of the patient population, more diabetics, but that's also, a fluid management in the OR issue where people get flooded if their blood pressures drop. So that, I think, is something we are learning to manage, and people are coming up with paradigms for care. But I think that is a more common issue afterwards. If you look at any of the large P.J. Devereaux trials, the number of people who go to coronary revascularization after any kind of surgery is so low that if you closed your cath lab, nobody would notice. So I think that at this point, I'm looking for active coronary disease. And that's about it. The comeback statement to that is, well, they can't walk, so how would you know if they have active coronary disease? I know for sure they don't have chest pain at rest, right? And so then we're really looking for maybe left main coronary disease. It's so rare that I think we're more likely to cause a problem by looking for coronary disease in everybody to find the small number of people who will have left main disease that you would even consider doing something on. But honestly, for any endo procedure, I would do nothing. And even for infrainguinal bypass, you'd really have to prove to me that there was a left main equivalent before I'd recommend fixing a heart. So I would say the number of times I have stopped surgery in the last year is fewer than 5.
Yeah, and I agree with everything Josh said. And I'll just say the other aspect of that is even if you find coronary disease, most of these people with CLTI have, infected feet and other problems. No one's eager to go chasing the coronaries in that setting. I mean, if it's stable, it's stable, and you just kind of manage them through it. I do think heart failure and, particularly stenotic heart valve issues can get a little bit tricky. It may require a little bit of management, but you're really not going to do anything procedural to manage that either. Yeah, of course, I studied under Josh, so I guess I'm an honorary member of SIN.
Yeah, heart failure patients worry me though, because they do worse when you do procedures on them, and they also don't heal well if their limbs are really swollen. So if you have time to get that under better control, which doesn't mean a heart cath, it's usually medication, I think that's worthwhile.
I basically try and diurese people until they don't have edema. Or whenever their creatinines hit, have a dead cat bounce and begin to go up again after with all the diuretics.
Dr. White, we do have results to share. If you're ready, Chantel can share her screen.
Let's take a quick look before we part. Let's take a look at the knowledge. So go ahead, Pete, when you can.
Yeah, and I'll ask Chantel to go ahead and share those results.
So we should have a comparison between pre and post.
And I believe these were just a sampling of the 18 questions, Dr. White.
Yes.
You want Chantel just to click through?
Yeah, please. Just because of the hour, we'll take a look at the data.
What's the difference between the orange and the blue? Is one orange is before, I assume, then, or?
Yeah, Chantel or Pete, tell us about the orange and blue. Which is which?
I will have to ask Chantel to unmute, or Jamie to let us know which is before and after.
I guess we can kind of tell with the direction.
I hope blue is after.
Yeah, I hope so too. For all.
But if people change their practice during this webinar, that's pretty exciting.
Yeah, no, I think, scroll through quickly so we can just take a look at.
This is Chantel. Blue is pre, orange is post. The reason there's such a difference in the numbers is because less people took the post than the pre. So we're not comparing 1-to-1.
So those are raw numbers, not percentages.
Yes.
Okay. Well, then Chantel, let's hold on going over that until we can really look at the percentages. Given the lateness of the hour, first, I'd like to thank Drs. Anand, Beckman, Banaka, and Galich for outstanding presentations. I learned a great deal. Want to thank my co-moderators, Mike and Joe, for working with me to put this together, and to the Society of Vascular Surgery and for their willingness to continue to drive practice standards, and finally to W.L. Gore for providing the unrestricted educational grant. So thank you all very much for being a part of this. I greatly appreciate it, and I wish you a very good night.
Thank you. Bye-bye.
Thank you very much.
Thanks, everyone. Yeah.
Thanks.